On behalf of the GAP MASLD MASH Community Network, I'd like to thank you for logging on today. I'd also like to thank Madrigal Pharmaceuticals for sponsoring this talk. Today, we're going to be talking about non-invasive testing in the liver patient. My name is Elizabeth Alqueza. I'm a physician assistant at Beth Israel Deaconess Medical Center. I work exclusively in hepatology with a focus on steatotic liver disease. Just a quick reminder to use this QR code to record your attendance for today's meeting. And I'd also encourage you to visit the GAP MASLD MASH Community Network to view Madrigal MASH disease state education and Madrigal Rezdiffra promotional program. So as we get started today, and to further convey the use of non-invasive testing, I'd like to start with a clinical case study, and I'd like to introduce you to our patient today that we're suspecting may have underlying MASLD. So Albert is a 65-year-old Hispanic male. He's right on the cusp of clinical diagnosis of obesity with a BMI of 29, and he's referred in the setting of abnormal liver enzymes. And he has an abdominal ultrasound, which is remarkable for increased echogenicity consistent with steatosis. So that's a common referral that I see in my practice as somebody who primary care has been following. They're noting the abnormal liver blood test, and an ultrasound shows a fatty liver. As we think about the patient's history, in terms of alcohol use, he hasn't used any alcohol since his 20s. As far as medical history, he's got a medical history consistent with type 2 diabetes, hypertension, hyperlipidemia. So right away, we're thinking, wow, he is right on the cusp of obesity and has multiple cardiometabolic risk factors, which may make him a patient whose liver enzyme abnormality is consistent with MASLD. On the exam, you find that he has abdominal adiposity, but no signs or stigmata of advanced liver disease. As you see in the upper right corner, there were some labs done. His triglycerides are 89. His A1C is a bit elevated in the setting of his known type 2 diabetes at 7.2. And he's had abnormal ALT. It's been noted for the past 3 years and is 1 to 2 times the upper limit of normal. As you look into other causes for abnormal liver blood test or chronic liver disease, that workup is negative. So we are thinking this patient's diagnosis is consistent with metabolic dysfunction associated steatotic liver disease. The question remains, however, does he have significant fibrosis? Is he our at-risk MASLD type patient that we need to be intervening and following closely? So as we're thinking about evaluating this patient, we want to consider some non-invasive tests to further our workup. And the landscape of non-invasive assessment of liver disease in 2025 is quite broad. Generally, it includes imaging biomarkers for liver fat, and that could include our ultrasound quantitative techniques, magnetic resonance spectrography, controlled attenuation parameter, and MRI proton density fat fraction. Some additional imaging biomarkers of liver stiffness, the shear wave elastography, acoustic radiation force impulse, vibration-controlled transient elastography measured in kilopascals and what we often think of as FibroScan, and then an MR elastography. There's some clinical prediction rules for fibrosis, and that could include our FIB-4 score, our NAVLD fibrosis score, the APRI, which is our AST to platelet ratio index, and some proprietary serum markers for fibrosis. So the list of 4 there are going to be blood tests, the PRO-C3, the enhanced liver fibrosis or ELF test, FibroSpect, and fibrometer. And finally, in the middle, you have some combined rules. So the FAST is going to combine your FibroScan with your AST. The ME-FIB is going to combine MRE with the FIB-4 score. And then the MAST is going to be the MRI proton density fat fraction combined with AST. In terms of today's talk, as you can see, there's quite a few non-invasive tests that could be considered, but we're going to focus on those that are in gold for the purposes of today's presentation. Sorry. So for our first non-invasive test that we're going to look at today, we're going to talk about the FIB-4 calculator. FIB-4 index is a simple, accessible, non-invasive test, and it utilizes AST, ALT, the patient's platelet count, and their age. So as you can see, the ease in which a provider could obtain this is quite easy. A lot of electronic medical records may even have a dot phrase that you could use to calculate this, and it's going to help you assess whether your patient has a high or low probability of advanced fibrosis, hence the FIB part of the FIB-4 calculator. It's often the first non-invasive test that could be applied to a patient with MASLD, and that really lies in the fact that it's so simple and accessible for a provider to get. There is going to be sort of cutoff points. Less than 1.30 is going to have a high negative predictive value for excluding advanced fibrosis. And conversely, a FIB-4 score that's greater than 2.67 is going to indicate your patient has a bit of concern for increased likelihood of advanced fibrosis. And then there is quite a large indeterminate range, as you can imagine, between 1.3 and 2.67. As we move on to our next non-invasive test, we're going to talk about the Enhanced Liver Fibrosis Score, or the ELF score. This is a proprietary blood test, so it's not performed at every lab, and it measures 3 markers of matrix turnover, really thinking markers of fibrosis, and those include hyaluronic acid, TIMP, which is tissue inhibitor of metalloproteinase 1, and P3NP, which is N-terminal procollagen 3 peptide. This score measures these markers of fibrosis and has a good diagnostic accuracy for advanced fibrosis. So if a patient has a score that comes back between 7.7 and 9.8, that could be consistent with significant fibrosis. I will say, in my own personal practice, we don't really order the ELF test frequently. It is an option for providers. Because of the proprietary nature of this test, not all insurance companies cover this, and your patient could end up with, an out-of-pocket cost for this study. So just something to kind of tuck in the back of your mind. Moving on to thinking about further non-invasive assessments with liver stiffness measurement. So stiffness is the ability of an object to resist deformation in response to an applied force. And we know that shear waves travel faster through a stiff liver. So liver stiffness increases with fibrosis stage. And so as we obtain these shear wave tests, we know that if they're traveling faster through a stiff liver and liver stiffness increases with fibrosis, patients are going to have higher scores as they have increased fibrosis. So here you're looking at images that are showing different forms of elastography. You have your transient elastography, MR elastography, and then down in the bottom, you have the point shear wave elastography and 2D shear wave elastography. And so those have a high sensitivity and specificity for detecting each stage of liver fibrosis. Okay, sorry, I'm just having an issue getting my screen to advance. Okay, so for the vibration controlled transient elastography, this is what we commonly know of as FibroScan. It is the most often used imaging biomarker for liver stiffness and steatosis. It's a point of care test It involves acquiring pulse echo ultrasound signals to measure liver stiffness. And as your patient comes into your office and presents to you their handout with their report, the two values that I spend time talking with the patients about after undergoing this study is their liver stiffness and their CAP score. So as they show you the results, the liver stiffness will be measured in kilopascals, and it helps to correlate the extent of liver fibrosis that is present. So a higher score, a shear wave that traveled faster through that stiffer liver, is going to represent the possibility of more extensive fibrosis in your patient. The CAP score, which is going to be measured in decibel per milliwatt, is going to help quantify the degree of steatosis or fat that's in your patient's liver. I often present this score to the patient and discuss whether they fall in sort of the more mild, moderate, or severe range in terms of the degree of steatosis that's present. And it's important to note that liver steatosis is defined as a median CAP score of 236 or greater. Both of these biomarkers can be used to assess disease severity in different etiologies, including MASH. So it's sort of revolutionized our workup of our patients and our ability to help represent those patients who may be at risk of more advanced underlying liver disease and who we need to really follow closely and intervene. So there's a few considerations when you are obtaining this FibroScan or VCTE in your patient. And the first thing you want to think about is, are there 10 valid measurements? As you can see, this image is showing the propagation map from a VCTE exam. You want to make sure those lines are parallel. The IQR and the IQR median are values that are helping determine the variability in the results. So if there's a tremendous amount of variability between your readings, that raises the question of whether their scores are representing something other than fibrosis. You want to look at the image quality. What was the success rate to obtain 10 measurements? And finally, this is somewhat operator dependent. So is your operator experienced? Have they had a high success rate in obtaining these measurements? There are some limitations of transient elastography, and initially, when your patient undergoes a FibroScan, if their ALT or AST is greater than 100, that's concerning that their degree of inflammation may affect the results of their FibroScan. So if that happens, it may be worthwhile to consider bringing your patient back in a few months and potentially repeating that scan to see if their liver stiffness is consistent with that reading when they were so inflamed. Cholestasis can play a role, and then some patient factors. So while this is a very easy test, takes 5 to 10 minutes, point of care testing, the patient does need to be fasting for accurate results 3 to 4 hours prior to the study. The patient who uses alcohol heavily may have lots of liver inflammation, which could affect the score. Morbid obesity may make this exam technically difficult and less reliable, those patients with BMIs greater than 35. And then if they have ascites or liver masses, that may play a role as well in limiting the accuracy of the study. The final non-invasive test we're going to touch on today is MR elastography. So this is another proprietary test. It uses software that utilizes shear wave technology. And an acoustic driver is placed on the patient and produces images called elastograms, which are quantitative, multicolor, cross-sectional maps of liver stiffness. Similar to elastography, there are some considerations to think about when you're ordering the study for your patient. One is their BMI. Are they going to be able to have an MRI scan? If they're morbidly obese, that may be prohibitive. Some patients can't tolerate MRI. They're claustrophobic and not able to have this study. Some patients have non-MRI compatible implants that would preclude this testing. Other factors that could affect moving forward with this would be iron overload, hepatic congestion, or potential issues with insurance coverage due to the costly nature. So this slide compares some of the most common non-invasive tests that we just discussed and includes the recommended cutoff points to rule in or rule out more advanced fibrosis. Each test has its limitations and its strengths. This is a really nice tool to think about when you're considering which non-invasive test to choose from. I'm not going to go through every piece of this because we've just touched on it, but sort of in summary, our FIB4 is utilizing the patient's age combined with their transaminases and platelets to calculate a score. We mentioned one limitation is that huge indeterminate range that often prompts the provider to need to order an additional study. It does have a low positive predictive value and can be less accurate at sort of the spectrum of ages. So that patient who's greater than 65 years old or less than 35 may have some limited accuracy. But it's easy to get. And if you can just use a dot phrase on your Epic or your online medical record, that may be the first step to get for your patient. And it does have a high negative predictive value. ELF testing is that proprietary blood test, could be costly. It is a send out test, but it can help rule in or rule out advanced fibrosis. And then finally, moving on to those imaging fibrosis biomarkers, you have your transient elastography and your MR elastography, both measured in kilopascals. And with that FibroScan and MRE, important to note when you're thinking about these rule out and rule in cut points that they are very different for those two studies. So result in an MR elastography does not necessarily mean the same thing as the transient elastography. So important to keep that in mind as you're interpreting those results. There can be confounding elements, as we talked about in the transient elastography, requires some experience on the operator's behalf, but very easy to get, point of care test and a high negative predictive value. And then conversely, the MR elastography may not be approved. It is more costly, but does have a high degree of accuracy. So let's go back to our patient Albert for just a moment. We've diagnosed Albert with MASLD. He's sort of your quintessential picture of your steatotic liver disease patient, but we need to figure out his next steps to assess his liver fibrosis. So looking at his labs, his ALT is 43, AST is 38. We'd rather see those under 30 in males. But we've decided to go on and get a FIB4 score for Albert. Comes back as 2.22, which falls in that large indeterminate risk range. So one tool that has been developed to help guide the application of the non-invasive test is this MASLD care pathway. We've already sort of started that pathway with Albert, and we know that he meets all three of the initial criteria. He's got those metabolic risk factors, he has diabetes, he has steatosis. So now we've looked at his lab tests, and he's got the elevated liver blood test, normal platelets, doesn't really have alcohol intake. And now we're moving on to that non-invasive test. And we started with the FIB4, and here we are at indeterminate risk with him. So if we follow this care pathway, the next step we want to think about is obtaining a liver stiffness measurement or a FibroScan in this patient. And his FibroScan score comes back as 6.7 kilopascals. So he's falling in that low risk range, which is great for him, but we would want to start by highly encouraging lifestyle modification, working on dietary changes, optimizing his underlying medical disease, getting better glycemic control, treating the hypertension and high lipids, weight loss and exercise, and then having him return in 2 to 3 years for repeat non-invasive testing. This set of patients could potentially be managed in the primary care setting. If you move over, I do want to just briefly mention that as the patient has sort of more moderate to elevated liver stiffness, so they're falling in that moderate risk category between 8 and 12 kilopascals, that patient should be referred on to hepatology for potentially a liver biopsy, MR elastography, additional testing that can help follow those at-risk patients and hopefully reverse the process versus progressing on. But then you also have your high-risk patient with a liver stiffness greater than 12 who will likely be treated as advanced fibrosis or cirrhosis and follow that care pathway. So very important that we accurately stage our patients in order to help capture those at-risk MASLD patients. So thank you for attending this talk today. I appreciate it. Does anyone have any questions?